Hello and happy Teach Me Tuesday / Thursday / Sunday, as this video is a compilation of 3 days worth of Teach Me Tuesdays that we are doing during the week of November 11th that will culminate on November 17th, which is World Prematurity Day or Prematurity Awareness Day. And this whole month of November is Prematurity Awareness Month, so I thought we'd pause right here in the middle of the month and really dive into prematurity and neonatology and what the NICU is and where we're going. And so I've decided to put all 30 slides from the Teach Me Tuesday post, so 3 posts, into one PowerPoint presentation. So kind of buckle in here with me. Some of it will go through faster than others. I'm going to give you an opportunity for you to pause this video and watch and kind of read through what is on there as I just kind of talk about it. There are slides with lots of words, so I'll just give you the opportunity to read through that as I'm kind of talking about it, but not necessarily reading it to you. So let's dive in. We know that these babies that are born prematurely need immediate and effective medical support, right? We talk about immediate effective PPV. What's a sign of effective PPV, right? Rising heart rate. That's the number one sign that your PPV is effective. So we want to get this going right away. On any intervention a premature baby will need during their entire time in the NICU. We have so much innovation going on in the NICU, from targeted oxygen therapy, delayed cord clamping, which we've talked about this month, the use of donor breast milk, all of these things that are kind of coming together, knowing parent presence, skin to skin. All of this has transformed the care we provide in the NICU and increased the survivability of the infants we take care of. So let's talk about some worldwide statistics. Every year, I love how this slide stretched that. About 15 million babies are born prematurely. Probably should have caught that, being real here. So that means they're born before 37 weeks gestation, and that's about 10% of global births. In the U.S. in 2022, which we have the most recent data on, the U.S. saw a preterm birth weight of 10.5, which was the highest recorded in 15 years. It's also interesting because we do have more babies that are being resuscitated and born and treated at younger and younger gestations. So that does influence the statistic, just so you know. The other thing is that complications from preterm birth remain a leading cause of death among children under 5. So about 1 million babies die every year from prematurity, and that is a worldwide statistic. So just keep that in mind. If we think about the economic burden of preterm births in the U.S., it's about a $26 billion annual cost. This is from medical, educational, lost productivity expenses on parents that are unable to work. So there's a lot going on. So what are the risk factors for having a premature baby? We're going to talk about risk factors and prevention back to back. So there might be a little bit of overlap here, but the number one kind of risk factor outside of premature rupture of membranes, so PROM or premature rupture of membranes, occurs in about 8% of pregnancies. We don't always know why a membrane ruptures. Sometimes it is the baby's way of saying, I need to get out, whether that is it's a hostile environment, such as an infection or a placenta that's unable to support the pregnancy, or there's been an accident. There could be other reasons for that to be happening, but in general, if the membranes rupture early and too early, there's not much we can do to stop that. And in fact, we need to get the baby out so that an infection doesn't spread. The majority of preterm births happen without medical intervention. Sometimes we take babies early because of cesarean birth or because of complications going on with mom, maybe an infection, maybe mom's blood pressure is too high and they can't get it down otherwise. Maybe mom is having a complication from a coexisting condition, such as a diagnosis of cancer. I remember taking care of a baby born at 27 weeks because the mother was diagnosed with cancer. She did carry the baby as long as they thought it'd be safe without her needing immediate treatment, and that was as long as she could go. And then she immediately started her chemotherapy and radiation treatment following the birth of her baby. So things like that. Multiple pregnancies increases your risks of your baby being born prematurely, and then chronic health conditions, which also goes into our prevention. So we don't have a golden standard to prevent preterm birth, because if we did, none of us would have jobs and we'd all be happy and everything would be great. But starting with a healthy pregnancy does decrease the risk of a premature birth. So that's going to do things like, can we get our blood pressure under control? Can we get our diabetes under control? Can we have an active and healthy lifestyle with a healthy diet? Are we avoiding tobacco and substance abuse? Are we, once a woman knows that she is pregnant, is she getting in and having early medical appointments, getting in before the 12th week of pregnancy, having at least 8 visits with a provider during the pregnancy, identifying some of these risk factors such as the blood pressure, preeclampsia, getting your urine tested if you're at risk for preeclampsia, getting tested for GBS. All of these are part of those preventions to make sure that the pregnancy remains healthy. We do know about our long-term outcomes. We're just going to talk about 5 today. We've talked about all of these in depth, so go back and check out previous Teach Me Tuesdays. But bronchopulmonary dysplasia, or BPD, which is a kind of a long-term, more severe version of chronic lung disease, happens primarily in babies born prematurely. And the younger you're born and the longer on mechanical ventilation, the greater your risk of developing BPD is. These babies are susceptible to infections. They have asthma-like symptoms for a long time. They may be on a ventilator with a trach for a long period of time. So that's probably our biggest, hardest risk factor kind of across the board. Then we have GI issues, and GI issues can actually go a lot of ways. I decided to kind of focus on a few that we do know a lot about. So if a baby develops necrotizing enterocolitis or NEC during their stay, this can lead to bowel damage, sepsis obviously, but also long-term the baby could end up with something like short gut syndrome or malabsorption. You can also have feeding intolerance and malabsorption just from being premature, having this inability to tolerate and digest the feeds, and that's going to prohibit the baby from absorbing the nutrients they need, which in turn can cause long-term growth problems. The other thing to kind of think about with GI is reflux. Reflux is kind of a dirty word in many NICU settings just because we don't know exactly what's going on with the baby unless they've had a pH probe or an upper GI to really tell us, hey, this is what's going on, because most babies are refluxing. We all kind of are throughout our day. When you're doing that kind of swallow, it is a question more of, is it a medical problem or is it a laundry problem? Is it that the baby's spitting up, or is the baby having poor growth, malabsorption, their calcium levels are terrible, we're noticing changes in their bones, they're having respiratory issues because they're aspirating? Then that becomes more of a medical problem. So I said I wasn't going to talk about it, and here I am. We also have our neurodevelopmental disabilities. So preterm birth is associated with a heightened risk of developmental delays, including cerebral palsy, learning difficulties, and behavioral challenges. We've all seen that. ROP, we know about retinopathy of prematurity. This is anything that says of prematurity, so apnea of prematurity. These are diseases that happen because a baby is born early. So this is abnormal blood vessel growth in the retina, primarily caused by high oxygen concentrations going on with the baby. So it's a balance of, we need to give the baby enough oxygen to be healthy and to be stable, and their brain to get the oxygen it needs, but we don't want to give them too much so we can protect their eyes. And then hearing impairment, preterm birth increases the risk of hearing loss. So this might be a baby that ends up with hearing aids or cochlear implants. Let's look at some trends over time. So these are global preterm birth statistics. You can see in the total births over time, in the 2010 is the blue column, you can see that it is slightly less. I would say, because we're looking at millions, it's really important to look at kind of what your axes are telling you. So it says preterm births in millions. In blue, 2010, we're approaching 14 million. It's just under the 14 million line. And then the pink, which is 2020, is closer to kind of between 13 and 14, closer to that 13. So it's changed slightly. However, as a total percentage of births, so maybe the total preterm births over time is less because we've had less births. But if you look at the percentage of births in 2010 and 2020, it's actually pretty stable, if not slightly more preterm births are happening. When you look at the distribution of preterm birth by age at birth, primarily, these are babies that are born greater than 32 weeks. So preterm is defined as any birth before 37 weeks. So somewhere between 32 and 37 weeks is 85% of the population, whereas we have only 4.2 at less than 28 weeks. So that is those ELBW or VLBW or micropreemies are a very small percentage of preterm births. I think that's really important to kind of think about. I think we think all of our babies are so small and tiny, and that's what we're always seeing in the NICU, but really we're seeing a lot of late preterm infants. As you can tell, I'm still fighting this cold. So let's talk about, this is from the Thursday part of the Teach Me Tuesday, some important evidence practices that have changed the NICU landscape. I say this frequently. Neonatology is a young science, a young medicine. It is a medicine that is constantly evolving. This is why in the NICU, we kind of have change fatigue, or this ability to say, we are constantly learning new things and we need to be able to kind of shift and pivot and try this new thing because we don't know that much, right? Even now in our resuscitation of smaller and smaller babies, we're learning that a 22-weeker is not just a smaller 25-weeker. We have different things we're going to have to do. We're going to have to change the fluids that we're using. We're going to have to change our modes of ventilation. So really, in my lifetime, right? I'm 43 years old. So in my lifetime, we have seen dramatic changes. Surfactant therapy was discovered in my lifetime. And I don't think I'm that old. So I've decided neonatology isn't that old. I mean, some days I feel really old. But let's talk about surfactant. So it's interesting when you participate in a double-blind study that doesn't feel blind because you can see the babies that are improving. And this was true of many surfactant therapy trials that were going on. They were double-blinded trials, and it was pretty easy to kind of tell who was getting the surfactant and who was not. And that's because their ventilator settings were changing. They were getting extubated. They were surviving at younger and younger ages. So this was first discovered in the 1980s. It has reduced mortality and the incidence of severe lung conditions such as BPD among premature babies born at or before 34 weeks in the NICU. It's very common practice. There's all different kinds of surfactant out there, but to not have seen surfactant is probably pretty rare. Even if you're in a delivery hospital that is a level 2 and may ship babies, you may have seen surfactant either from your transport team that comes, or maybe you keep some for an emergent situation. So most likely we've all seen that. An interesting side note, I love talking about this. Did you know that our president, John F. Kennedy, had a son named Patrick? This was his third child. They had already had a stillbirth of a little girl, and this was their fourth. So they had, Caroline was already born, and JFK Jr. was born, and Patrick was born. And because of the stillborn baby, they had kind of increased monitoring of Jackie O. And Patrick was born in about 34 weeks, and he was rushed from where he was born. I think they were out in kind of like in the Nantucket area. I don't remember exactly where he was born. And he was rushed by ambulance to a bigger facility, and he died of hyaline membrane disease. So this is in the 1960s, right? He was born at 5 pounds, somewhere between 34 and 35 weeks. They just say he was born 6 weeks early. And hyaline membrane disease is now kind of what we call respiratory distress syndrome or acute respiratory distress syndrome. It's what we would treat with surfactant. And because of his death, they realized we need to be studying this more and more. They poured more money, more evidence, and more money and more manpower into this to produce evidence-based practice changes that NICUs could do to help these babies survive. In today's evidence, less than 1% of infants born at 34 weeks with respiratory distress syndrome die. I just think it's super interesting to think. So then, of course, we have maternal steroids. So maternal steroids was also something that was in so many blinded trials that they actually stopped the trials early because they found such a good response to using these steroids. So this is really given if we think imminent preterm labor is coming, maybe there's been a premature rupture of membranes, maybe mom's in active labor that we're unable to stop. Our goal is to give 2 rounds of steroids about 24 hours apart. So it takes a full 48 hours to really kind of get them in, and the more we can get in, the better. That's just kind of the standard protocol. But it has shown to reduce neonatal RDS and neonatal mortality by about 40%. So they're highly effective in decreasing the need for intensive respiratory therapy. This is something that is a data collected item so that we can see how well we're doing on getting them in. There is ongoing research about when should we be doing this. Currently, practice says when a mom reaches 24 weeks gestation. There are places doing it when the babies are younger and younger, though, so that is an ongoing thing that's happening. Additionally, throughout our time in the NICU, we have looked at targeted oxygenation and ventilation. We used to resuscitate all babies on 100%. We used to keep babies on 100%, and then we wondered why all premature babies when they grew up couldn't see. So now we do targeted oxygen saturations and even have places that change them. Maybe you do the OWL method so that you're changing your oxygen limits throughout the baby stay. As they get older, we will tolerate higher levels or lower levels, whatever it might be, throughout their stay. So this has been a big part in reducing the risk of retinopathy at prematurity and chronic lung disease. Again, it's so important that we remember to keep our oxygen in a safe zone so that we are oxygenating the baby and we're not worried about hypoxia or hypoxemia, but that we're not using too much and we find that sweet spot. Another important evidence-based practice that's changed the landscape is donor breast milk. So donor breast milk, especially when fortified, we all know that donor breast milk has its drawbacks, right? We don't want a baby to be on donor breast milk forever. We know that it is not as nutritionally sound because of the pasteurization process, which is necessary. But studies have shown that it can significantly reduce the incident and the risk of necrotizing enterocolitis. And there's been also incidental findings of reduced hospital stays where donor breast milk is used. So there's an example of a study here. There was a review that found that infants receiving donor breast milk experienced an average reduction in hospital stays by about 11 days in observational studies. So this has not been replicated in a randomized controlled trial, so it's important to point that out. But most units are using donor breast milk if they have VLBW babies. So this is specifically given to babies that are born less than 1,500 grams, maybe 1,800, depends on what your unit does, and something just to consider. Some other changes that we know, we talked a lot about delayed cord clamping in the last couple of weeks, especially in conjunction with our hyperbility lecture last week. So we kind of know what delayed cord clamping is about. If not, you can go back and check that one out. And then our skin to skin care. We talk so much about the importance of skin to skin care, and it's even becoming more important. There are more and more studies out that show that this is also helping our parents so much with bonding and their mental health. Mental health of the family unit in the NICU is going to be an emerging research that we're going to talk about as we go through here. But it is something that we know so much about. I went to a webinar this week about it. I don't know if any of you were on that webinar, but about follow-up and follow-through. But they were mentioning even this idea that if you don't know this, there's a higher divorce rate among NICU families, especially the longer the baby's been in hospital. We also know that about it's the increased likelihood of divorce and when a child has died. So this kind of goes along with that. What we need to do is how can we enhance our parents' stay in the NICU? And kangaroo care is one of those ways. And in resource limited settings, kangaroo care is kind of what they do to keep babies warm. So we can do it. Which brings us to the idea of incubators and warming tables. The importance of thermoregulation. Again, we talk about the youngness of neonatal medicine. The idea of the youngness of the NICU, right, in neonatology. So I have this little picture up in the corner. I added that to the slide. And this is this idea of the incubator that was kind of hanging out on Coney Island. It's so weird to think about. That first started in the early 1900s, so like 1906, 1907. So originally, the idea of an incubator came out in the late 1800s by Pierre Boudin. I'm probably going to pronounce it wrong. And he had this idea of like, babies are getting really cold. And so he brought the incubator to the World's Fair in Berlin. So wild. In 1907, so not that long ago, he wrote that the newly preterm infant becomes chilled with astonishing rapidity, right? So That is an important statement. I wanted to read that to you with astonishing rapidity. So, very quickly. It is still important to this day, and it is why incubators and warming tables have transformed neonatal care. If you can keep a baby warm, the baby is going to do much better. Cold babies, for every degree a baby's temperature drops, their morbidities and mortalities rise. So, keeping that baby warm, tracking your baby's temperature, using your sophisticated equipment is key to this. And so, this is another important change to the NICU landscape, is getting better and better with our incubators. Now our incubators can do humidity, so it's also helping with our skin. They have skills built in. They can turn around. You can pop the top to do your procedures. When I started, they did not do any of those fancy things. So in my career, so originally I talked about my lifetime, now I'm talking about my career. In my career as a NICU nurse, there was not a giraffe omnibed. So just think about that. That is a new, invention and follow-up to our initial incubators and warming tables. So we are still on the precipice of so many great things coming forward. Obviously, our neuroprotective changes, so early developmental assessments, getting therapies in. I remember physical therapy at the beginning, and it was really meant for older babies that had been there. Maybe we were starting to worry about their head or torticollis. Now it's like we get them involved early, we get them involved often. Remember that a baby's occupation is to eat, sleep, and breathe and poop, right? So that's sometimes what our occupational therapy is helping with. It's so great. Positioning devices, there's so many great ones out there. I don't know what you're particularly using, but Dandelion is a great brand. It's out there. I highly recommend. They have great positioning devices. And then we have our neuroprotective strategies like the 72-hour midline period, which we have talked about in our IVH prevention. And then parents' presence in the NICU. I have a friend, this is wild. I believe he's 50. I hope he never sees this in case he's not 50, and I'm telling you that he's 50. But my sister just turned 50, and he's just a little older than her. And he is a triplet. So try that on for size. He was born in the early 1970s as a premature triplet infant. There's 3 boys. They all survived. His parents saw him when he was born and on the day of discharge. Let that sink in. So in the last 50 years, we have realized that we are not just taking care of a baby, we are taking care of a family. So this is increased parental presence, active participation, seeing our parents as caregivers, that they should actually be the primary caregiver, has been a huge advancement in neonatology. So cannot stress that enough. Skin to skin, feeding, basic care, massage treatments. If the baby's going to go home with any sort of medical complexity, such as a trach or a G-button or a feeding tube, getting them in there, showing them how to use it, showing how to put it all together is so important. Frequent visitation, not treating our parents as visitors, saying, no, this is like your place. You need to come in and be a part of this. So I just think it's so important to keep that in mind, and to realize, even when I started, there was visiting hours, right? Our parents visited from 7 to 7. That's in the last 20 years. So if you are still working in a unit that has visiting hours for parents, let that be a project that you invest in to change the landscape of your unit. So we just covered kind of the history and things that have improved neonatology. So let's talk about where neonatology is going. What is it going to look like? What are we actively studying? I did a little fun activity with myself where I thought about what the NICU could look like in the next 5, 10, or 15 years, so bear with me. So let's look at some key areas. This is what I was talking about, where there's a lot of words on the slide, and I encourage you to pause me and to read and to kind of think about what these are talking about. But artificial wombs must be at the top of all of our minds, because this is something that is actively being studied. I saw a presentation on this at a conference, another plug for a reason to go to a conference. But these are these next generation incubators that are going to simulate the in utero environment. And it's going to allow us to control so many more things. They're trying to figure out how they could pipe fluids in almost like you still have a placenta. It is mind-blowing. Stem cell therapy, regenerative medicine. They're doing clinical trials on the use of stem cell and BPD. So there is a lot going on that we don't even kind of know the beginnings of. Genomics and looking at your genome. Again, at a conference, I was talking to someone who is working with mapping the genome and getting babies' genomes so that we can intervene on issues that we know they're going to have sooner. And I was like, I wonder how that would be helpful. And then it really dawned on me, these are not just for genetic anomalies. What if there are markers for BPD and we could be intervening earlier? What if there are things in their genetics that tell us that they are going to have absorption issues or feeding issues and we can change their formulas earlier, their concoctions, their breast milk? Maybe we know that they're going to have a dairy issue and we can have mom off of dairy sooner. I just think there's a lot that we're going to learn about what our genome is telling us, which also goes along with our microbiome. And the most ridiculous aha moment with my husband this week, that he was like, do you know that they're studying the microbiome and they think that what's going on in your gut is also affecting your health? And I was like, yes, I did know that. So also thinking about what we could be doing with our microbiome, we're still looking at probiotics as a potential for our NEC prevention. So that's going on, supporting our gut health. I've heard of probiotics for reflux, that dreaded word again. So lots going on with the microbiome. I went to a conference I always measure things by my children. So my 11-year-old, I think, was born. So somewhere between, let's say, 10 and 14 years ago. It was in California, and I went to a whole presentation where they're showing us the microbiome and what they're studying and how there's, what our gut does and how it turns in all of this. There's so much going on in there that they had barely touched the surface. I wonder where they are on that project now, but very interesting. We've talked about extrauterine environment for neonatal encephalopathy. So this is artificial womb to really kind of prevent what's going on with the babies getting kind of this encephalopathy from their prematurity. Brain monitoring, neuroprotection. If you're using NIRS or NIRS, near infrared spectroscopy, it's watching that oxygen and blood flow. I have, trialed it at a facility I worked at. There are places using it. I think they use it in the CICU, the cardiac ICU, a lot. But if we could be using that on our preterm babies, even more, could we be seeing changes? Even if we are doing, they put it both down by the liver and on the top of the head. What is going on down there? Would we be able to see changes in the gut and changes to your renal, your kidney blood flow? That could then maybe tell us that something could be happening with NEC. Lots coming out there. Genetic testing, so more genetic markers are being looked at for preterm birth predictions. Wild. Less invasive surfactant administration, otherwise known as LISA. There's also SALSA trials, which is using supraglottal surfactant administration, the ENSURE method. There are lots of ways that we are looking at how are we giving surfactant. So this is the thing, we know that surfactant is so important, but we also know that mechanical ventilation is damaging to lungs. So how do we reconcile these two things when they are both so important? So that's why I think the LISA, less invasive surfactant administration, is so important. So here we go. Bear with me. This is just kind of me projecting. Where do I see neonatology in 5 years? I do see more non-invasive monitoring. I even think that there's changes going on with wireless leads, things like how can we be using our transducers to tell us more about what's going on in the baby's blood. I think that we will have more family-centered care. We will have families presenting in rounds. I think that we're going to have better ideas about what's going on with our genome and whole genome sequencing. What is that going to be telling us? I think we're going to be getting on the precipice of that in the next 5 years. In 10 years, will artificial wombs or artificial incubators become the standard of care? I don't know. I think we're going to be using a lot of stem cell and regenerative therapies. I think that's going to really help with things like NEC and BPD. So I really think there's got to be something that we are missing. Well, obviously, we don't know it yet with stem cells. So that'll be real interesting to see. In 15 years, I think we're going to know more about the baby than we could ever imagine possible, whether that's from the microbiome, the genome, the genetic profile. Artificial wombs are going to become totally normal. Couplet with mom and baby care in the same room is going to be really normal. I think we're going to support our parents better. I think we're going to have less long-term outcomes. I think we're also going to have more support for families when they go home. I think that the transition to home is going to be completely different than it is right now. I believe we would be sending babies home earlier because we know they thrive in their homes, with perhaps doing NG feeds at home. I think our follow-up and follow-through is going to be way more intense than it is right now, which is what it's needed. So how are we going to do that? Who are we relying on? So the March of Dimes is a big company that aims to prevent premature birth, birth defects, infant mortality. They use their funds to research prematurity causes and prevention, and then they support our families so much. If you've ever been to a March of Dimes walk or reunion, it is like life affirming. They're just wonderful. So great organization there. Global registries such as the Vermont Oxford Network really collect hospital data. They bring it together and say, hey, where could we be doing better? What are the changes in the landscape that we're seeing right now? Are we seeing more 22-weekers born? Are we seeing more resuscitation? Is it specific to a certain area? What are we seeing if a baby is born less than 500 grams as far as their outcomes go? They also do quality improvement, so looking to reduce those morbidities, chronic lung disease, neck infection, etc. So we've got great support there. We've got these two that were run by families, NEC Society and Graham's Foundation. So the NEC Society focuses on raising awareness around NEC. It supports research on NEC prevention. They do great webinars, highly recommend them. They provide educational resources like the webinars. They also allow families to kind of know what NEC is, because sometimes we're not great at kind of warning families that that's going to happen. Graham's Foundation provides support to families of preemies through customized care packages. They raise awareness on the challenges of prematurity, and then they connect families and resources and offer mentorship from similar experiences. So I think that's really great too. We've made it together to slide 30. Are you proud of us? We're only at 32 minutes. Not too bad for me. So every year, approximately 13.4 million babies are born premature. They face a lifelong risk of health challenges. We have organizations like the March of Dimes, the Vermont Oxford, the NEC Society that's working tirelessly to prevent these outcomes. We have things that we're looking at like less invasive surfactant, ways to measure our brains, way to look at our guts. And we are using our interventions that have already been successful, such as steroids, surfactant therapy, delayed cord clamping. We are watching what the future is. We are looking at artificial wombs. We are looking at neurodevelopmental strategies, because together we can highlight the resilience of a preterm baby and look at the importance of the continued support of families navigating this journey. So Sunday, if you're watching this after Thursday, is World Prematurity Day. And I hope that you pause and think about the great work that you're doing. I'm so proud of you. I'm so grateful for you that you're out there doing that hard work. And I hope that you don't have change fatigue, but you embrace the change, because we have so much to learn, and we're going to continue to grow and get better. And if you're the parent of a premature baby, I hope you know that you're doing great, and I'm so proud of you. And I hope that you can help influence the future by joining your hospital's parent we have parent councils and things that you can do to get yourself involved to help change the landscape of prematurity. Have a great day.